All right, I got 6 common responses to my question about why clinicians are doing dry needling, what it does, what it treats, how it works, where it came from, physiological implications. I got 6 most common reasons. The first reason, or the first response was 50% of you saying it's completely bogus, I don't do it, refuse to do it. Thank you. Now I'm going to break down why you can actually tell patients you don't do it. The other 5 responses I'm going to break down now. I'm going to debunk all of them so you know exactly why you no longer ever have to do dry needling. Even if you think it works right now, by the end of this video, you should understand it's completely bogus. So I know people that are in my age group watched Mr. Rogers when they grew up. And Mr. Rogers had this really cool place called the Land of Make-Believe. And in order to talk about dry needling and trigger points, we need to take a trip into the Land of Make-Believe. So here are the 5 reasons you guys gave me in the Land of Make-Believe that support dry needling. So number 1, increases range of motion temporarily by desensitizing the muscle, I guess. Okay. So what you're saying is we're going to desensitize the muscle so we can get a short-term increase in range of motion. Range of motion, remember, is a symptom. So if you're treating lack of range of motion, you're treating a symptom, you are not getting to the root cause. And my other question is, why would you want to desensitize something? Shouldn't we be increasing sensitivity? Shouldn't we be maximizing normal sensitivity, which would be a function of physiology? Why would we decrease sensitivity in order to temporarily increase range of motion? That doesn't make any sense to me. Hopefully now that doesn't make any sense to you, because there's a way that we can increase range of motion by increasing sensitivity. I'll talk about that at the end of these 5 reasons. Trigger point release. Okay, so let's dive into the history of trigger points. Did you know that trigger points were first found in the early 1900s? Now researchers today, when they are put to the test to find trigger points, they cannot find them. So in 2025, experts in dry needling can't find these microscopic trigger points or fibromatosis or whatever they're called. But you think in the early 1900s, somebody could find these elusive trigger points that are microscopic. So somebody in the 1900s found these trigger points. I call bullshit, okay? Because we have proven over and over again that trigger points do not exist. Fibromatosis do not exist. Does a muscle spasm exist? Yeah, sometimes it exists so much that you can feel it. Like somebody gets a Charlie horse or a cramp and you can feel that spasm. That would be called a muscle spasm. That is not a fibromatosis. And by the definition of dry needling, that is not a trigger point. So if you're sticking a needle in somebody to release a microscopic trigger point, how in the hell are you, with no guided imagery, no magnification, how are you finding this trigger point? You're not. Because they don't exist. It's like saying that you make saddles for unicorns. No, you don't. You make saddles. There's no such thing as unicorns. So you're sticking needles in people just randomly. Maybe you're finding a big muscle spasm. That's not a fibromatosis. That's not a trigger point. You're not treating those things because they don't exist. Okay? So trigger points don't exist. And if you have a muscle spasm, isn't that muscle spasm a response to something going on a physiological level that you, as an expert clinician that's probably went to 7 years of school, shouldn't you understand that? Because you went through physiology in high school, you went through physiology in undergrad, you went through physiology in grad school. Why don't you understand how to apply physiology? Because you don't get taught that in school, unfortunately. That's not on boards, so they don't teach you how to apply physiology. If you knew how to apply physiology, you wouldn't be attacking trigger points, which don't exist, and you wouldn't be attacking muscle spasms, which do exist, because muscle spasms are a physiological response to something else, which we'll get to at the end of this video. You're trying to, I love this one. I love when people tell me this one. You're trying to create micro trauma to the tissue. And some of these people said, so your body focuses on healing. Let me get this right. It's our job as a clinician to cause trauma to a patient by jamming them with a needle to cause trauma, tissue damage, and bleeding. That's a good thing. Really? This sounds a lot like the witch trials and like medicine back then, where if you were sick, they just stuck leeches on you and said, oh, we'll just suck it out. What? No, your job is not to hurt your patients or cause trauma or make them bleed. Your job is to figure out what the root cause of their pain, their lack of range of motion, their swelling, their instability, which are all symptoms. So if you're treating any of those things, you're not getting to the root cause. Yes, I said that. You should never be treating pain, lack of range of motion, tightness, instability, weakness, because those are symptoms. If you're not getting to the root cause of those things, and the root cause of all of them are the same. So stop thinking that it depends or there's a different treatment for different things. Every person that came in this clinic that's on the wall back here came in for the exact same reason, which we're going to get to at the end of this. So causing micro trauma, hurting your patients more so they have to heal more, to me, sounds idiotic. If you can explain how causing trauma and tissue damage to your patient is a good thing, please reach out to me and let me know. Reason number 4, increasing blood flow to decrease pain or increase range of motion or decrease spasm, whatever. So let me get this right. Increasing blood flow. So you're going to stick a needle in somebody and that increases blood flow. Last time I went to school, now I got out of school a long time ago. Maybe human physiology has changed over the last 20 years, but last time I went to school, the way you increase blood flow is to increase the heart rate. And the way you do that is to increase activity level or do an exercise, something like that. So I don't understand how sticking a needle in my forearm right here increases blood flow to my forearm, unless we're causing enough trauma to cause micro trauma, which again is idiotic. So if you want to increase blood flow, don't cup them, don't needle them, don't massage them, don't stretch them. None of those things increases blood flow. What increases blood flow is activity and exercise, okay? And then the last, also, if you're trying to increase blood flow, explain to me how increasing blood flow solves your plantar fasciitis patient's problem. Tell me how increasing blood flow solves your subacromial impingement problem, your tension headache problem, your post-ACL rehab problem. How does increasing blood flow all by itself, and that's the only thing you're going to do, how does that address anything? I'll teach you a different way to address that at the end of this video, which is coming after this last one of the 5 reasons that you guys gave me. So, and this came from a PT student, and this absolutely kills me that they keep teaching you this bullshit in school. You do not need another tool in your toolbox. You need to take tools out of your toolbox, because I would guarantee if I sat down and I broke down that toolbox with you, none of those tools that are in your toolbox, needling, cupping, stretching, foam rolling, Theragun, Graston, manipulation, nerve glides, corrective exercises, none of those things get to the root cause. So the more tools that you put in your toolbox, understand every single one of those tools, E-stem, newbie machine, ultrasound, traction, those are all symptom modification gimmicks that make you think that your job is to make your patients feel better. And it makes your patients think that they're coming to you because they have pain. They're not coming to you because they have pain. They're coming to you because they have a neuromuscular problem, insufficiency, dysfunction, whatever you want to call it, that is causing symptoms, pain, lack of range of motion, swelling, instability, weakness. It is your job as a clinician to get to the root cause of that problem. And the more tools that you have in your toolbox, the further away from the root cause you get, and you chase symptoms all day long, and then you wonder why your patients aren't getting better. So you go get another tool and go to another CEU course and see somebody on Instagram with another fad, and you start doing that. And 5 years into your career, you figure out you have this gigantic toolbox that does jack shit for your patients. You do not need another tool. Get the tools out of your toolbox. Use your critical thinking skills. Oh, I forgot, they don't teach you critical thinking in college, in grad school, my bad. At least you can use the application of physiology that you used in grad school. Oh, my bad. You didn't learn that either. Well, you can use how you understand how biomechanics and anatomy relate to the root cause of dysfunction. Oh, shoot. They didn't teach you that either. You did not learn how to become a clinician in school, which is why they keep telling you to put bullshit in your toolbox. The only way you're going to learn how to become a clinician is on your own after you get out of school, or if you're smart enough to go through the shift while you're in school. Now, let's get to, okay, so the PT student said, and so this toolbox, a tool in your toolbox is for pain management. Once again, your job is not to manage pain. Your job is not to get rid of pain. Your job is not to make people feel better. Your job is to get to the root cause of physiologic dysfunction, reverse the root cause, so when your patients leave, they have normal neuromuscular function, which drives normal gross function, which lets them go back to do whatever they want to do, symptom-free. All right, so now let's go through what you could be replacing dry needling with really easily, really effectively, and it makes complete sense. So if you want to increase range of motion, figure out why the range of motion is decreased in the first place. Muscle spasm, why is the muscle spasm happening? We already know through physiology that muscle spasms are secondary to neuromuscular insufficiency or neuromuscular inhibition. What causes that? A lot of things. What could reverse that? One thing. So if you know that one thing, and first you know how to assess each individual muscle for neuromuscular, either facilitation or inhibition, and when they test positive for inhibition, you would know how to reverse the inhibition. The only way you're going to know how to do that is to take the shift, because that's all of our patented technology that we would teach you in the shift. So if you know how to do a gross assessment, then break each individual muscle down to find inhibition, to prove what you thought you saw in the screen was actually happening, because the eyeball test is never going to be right. So you put them on the table, you break them down, you test each muscle for inhibition versus facilitation. You reverse inhibition when it's present. You do that throughout the whole body. You get them off the table. Guess what? Muscle spasms go away, because muscle spasms is hypertonicity from insufficient neuromuscular control. If you can restore neuromuscular facilitation, that is control, now the spasm goes away. You don't have to create microtrauma. You don't have to tell stories about trigger points. You don't have to go to the land of make-believe. You can actually stay in reality and fix the root cause of the problem. So when the muscle spasm goes away, strength increases. Strength increasing equals range of motion increasing. So you can increase range of motion two ways. You can either turn the muscle off so it can't do anything, and then you got motion and flexibility all over the place, which is what drives injury in the first place. So why would you do that with stretching, foam rolling, Graston, myofascial release, whatever bullshit you're doing for that? Why would you do that when the other way to increase range of motion is to increase strength? So increase range of motion by taking strength away, or increase range of motion by maximizing facilitation? I choose option 2. So when you maximize facilitation, spasm goes away, range of motion increases, and more importantly, range of motion, strength at the end range of motion, stability throughout the full range of motion increases, and now you have normal function, which maximizes function, which is athletic performance, and decreases the risk of injury. So in one step, we did everything that you were told dry needling does, but it doesn't do. And when every one of these answers that you guys gave me was temporary decrease in pain, temporary increase in range of motion. Why do temporary things that are pathological when you could actually maximize function for a long period of time? I don't care if my patients leave my clinic pain-free, and then by the time they get home, all of their pain is back. That means I'm a lousy clinician. What they should be doing is leaving my clinic with normal function, even though their pain might be 2 or 3 out of 10. And an hour from after that, they keep moving around, they keep doing things, and then their pain goes to 0. So it's not important that your patients feel better when they leave. It's important that they function normally when they leave, so they feel better after they leave, and they keep feeling better after they leave. That should be what you're working towards. not temporary feel better. So, do we need to increase blood flow? No. Increasing blood flow has nothing to do with neuromuscular physiology. Stop worrying about blood flow. Okay? When they get up and they get active, because now you've increased mostrability, which is motion, strength, and stability all at the same time. They have full range of motion, full stability getting there, full ability to get out of the end range of motion and reverse that. So they have a short amortization phase. Then they can go exercise, and then they can increase their own blood flow. Crazy. Okay? So notice I did all of that with one tool. I have no tools in my toolbox. I have one tool that I take with me everywhere. It's related to my critical thinking. It's related to applying physiology. It's related to explaining science to patients. So instead of telling them stories about trigger points, which don't exist, I can actually talk to them about what physiology does. You know, what you learned in school, what physiology does, how it works. And that's how patients get better after one visit. They don't have to come in two to three times a week for 4 to 6 weeks, 6 to 8 weeks, whatever. When you're ready to do that, let me know. We'll get you away from the trigger point or the dry needling stuff. And understand, dry needling came into fashion. Even though this guy found trigger points in the early 1900s, it didn't come into fashion until the early 2000s. Why did that happen? And who created trigger points in dry needling? Physical therapists did. Why did they do that? Because they were losing business to acupuncture and they needed a way to battle acupuncture. So they made up trigger points and they found some obscure reference to fibromatosis in the early 1900s, which was absolute fuckery. So that's why trigger point dry needling exists. So physical therapists could get business away from acupuncturists. And now it's turned into this thing that has basically hamstrung every PT clinic across the nation, because now we have physicians who know absolutely nothing about root cause analysis and physiology and how that relates. They see some idiot physical therapist marketing to them, hey, I do dry needling. It's this greatest thing. We stick these needles in people and they do crazy stuff. Do you think physicians actually think about what is going on there? No, they just circle dry needling. So now we have dry needling being, not only dry needling being referred by physicians, now I just had a physical therapy student tell me they're learning dry needling in school. And I thought that is absolute idiocy. But then I also remembered, well, you also learn stretching in school and you also learn massage in school. And they're probably still teaching you E-stem and ultrasound and traction and all the other old school physical therapy fuckery that's still out there. So they might as well just throw dry needling in there and save you the $800 weekend course to get dry needling certified. Just wrap it up into the tuition that you're going to be paying off for the rest of your life, even though you're not going to have a job that's going to help you pay that off. Okay, I'm going on a rant. Don't want to do that. But now, if you understand everything that I talked about, you should never, ever reach for dry needles, stick a needle in somebody, talk to somebody about trigger points, and you should be able to defend your thinking when you start applying what you should have learned in school. And when you're ready to learn how to apply all that stuff and you're ready to learn the critical thinking skills that you never got in school, let me know and I'll teach you that.